So this presentation is a synopsis of a lot of the research I did during my PhD. I'm Dr. Henry Glyde, by the way, and what I've been doing since my PhD, looking at trying to predict exacerbations of chronic obstructive pulmonary disease with AI. So what is chronic obstructive pulmonary disease? It is a disease of long-lasting lung damage that usually occurs in later life. And it's an umbrella term for two conditions: emphysema, which is the scarring of the lungs and the breakdown of the alveoli in the lungs, which makes breathing much more difficult, alongside chronic bronchitis, which is inflammation and swelling of the bronchioles in the lungs, which also makes breathing much more difficult and results in a lot of coughing of mucus up and wheezing. COPD is a big global problem. It's the fourth leading cause of death worldwide, but it's also a major problem in the UK. So there's currently 1 million people who are diagnosed with COPD, but there's about 2.2 million who are currently living undiagnosed. It costs the NHS 1.9 billion per year, half of which of these costs are driven by exacerbations. Exacerbations of COPD being the current symptoms becoming significantly worse, so breathing becomes much more difficult because you have inflammation and swelling of the lungs, and that can often result in an emergency admission. In fact, it's the second most common cause of emergency admissions in the UK, and it really drives winter NHS pressures. So this is a serious issue that we've been looking into. So what is COPD and how do people get it? Well, in the past, a lot of people have associated people getting COPD with smoking because that's one of the major drivers of COPD, but actually it's much more complex than that. And there's 5 types of COPD, one being your genetic predisposition, type 2 being early life events, which affects your lung physiology and lung size and the trajectory of your lung function throughout your life. Type 3, infections driving lung damage. Type 4, exposure to smoking and environmental tobacco smoke. And type 5, exposure to environmental pollutants. This could be just pollution in the air, or it could be log burners in the house. But realistically, COPD is a combination of these 5 different types. It's not just one in an individual. It's a complex interplay of all of these 5 things. And again, people with COPD often suffer from exacerbations, which is a flare-up of their symptoms, breathing becoming more difficult, more coughing, more wheezing. In fact, breathing can become very difficult, and people can end up in the ICU. And actually, if a patient is hospitalized for COPD, the case fatality rate is about 15%, and the 5-year survival rate is about 50%. So the risk of morbidity and mortality after a severe exacerbation is extremely high, and it really dramatically decreases quality of life for patients. There's a significant deterioration in their overall health status, but especially with regarding to their respiratory systems and their COPD and their lung function. But we do know that earlier intervention and correct intervention of exacerbations actually improves respiratory-related quality of life and quality of life. And we think that this could result in a reduction in hospitalizations, improvement of quality of life, and a reduction of costs. But there's actually no technology that currently exists that can accurately predict or prevent exacerbations. And again, going back to what I was saying earlier, we know that treating exacerbations earlier improves outcomes. A lot of evidence comes from this study on early therapy showing that the delay between treatment results in a longer recovery time, and also more treated exacerbations results in reduction in overall symptoms, better quality of life, and more activity. So that leads on to what we've been trying to do for the last few years, starting with my PhD and working on the sensing, predictions, and alert and COPD exacerbation studies. We knew this was a really important issue to be working on because the James Lind Alliance Priority Setting Partnership identified that the 3 most important questions to patients were identifying ways to distinguish exacerbations for other symptoms, needing better ways to prevent and identify the onset of exacerbations. And to tackle this issue, people have tried a variety of methods. So for a long period of time, people have just been using remote patient monitoring alone. So that's the use of digital spirometry or pulse oximetry, methods to measure cardiorespiratory variables like heart rate, oxygen saturation, lung function. And that's been reviewed by a clinical monitoring team at a regular basis. So this can be made up of scientists, clinicians, and nurses. And when they identify that a patient is deteriorating, then they might interject with an intervention. So when a patient is going to have an exacerbation, use of oral corticosteroids and antibiotics can reduce the severity of exacerbations if used in a timely and correct manner. But there's two main issues with that. The remote patient monitoring hasn't been shown to actually be effective in a lot of instances, be effective in reducing exacerbations. And actually is quite a resource-intensive approach to this challenge. Having a team of individuals monitoring, a million people with COPD to try and prevent exacerbations is unfeasible with the current state of the NHS. And there has been some work now more recently looking to see if AI could potentially predict exacerbations, so you wouldn't need a clinical monitoring team. You could have a machine learning algorithm that identifies deterioration perhaps more accurately and earlier than a team of remote scientists could do. But so far, nothing has proven to be efficacious in randomized controlled trials yet. But there's been a number of studies that have shown quite high accuracies, but yet nothing has been proved efficacious in trials. So our approach is different from both this remote patient monitoring and also a lot of the other approaches to this challenge, where we're going for a much more passive, low burden approach. And we believe that this kind of low burden will make patients be engaged with the system for longer and result in better prediction, maybe better outcomes, and see that reduction in hospitalization and improvements in quality of life. So in the first part of the space studies, we collaborated with MyM Health and their app, myCOPD digital therapeutic, for managing COPD symptoms. And in this app, there's methods for looking at inhaler technique, tracking your symptoms, looking at pollution and pollen count, pulmonary rehabilitation, a variety of tools that people with COPD find very useful for better managing their health. And we were provided with access to, at the time, it was probably around 30,000 patient users, but I think it's more now. And we've done a more recent study, which we'll go into in a bit more detail. So the first challenge that we had when we first did this modeling approach, which was probably back in 2020, 2021, was how do we identify when patients are having an exacerbation within the app? So this kind of internal validation. And we found that through co-creation meetings with academics and engineering academics and clinicians, the academic respiratory unit and the School of Engineering, Mathematics, Technology, that we could distinguish stable health from when patients are exacerbating. And in the end, this led us to create a label where we created a window of 14 days where patients couldn't have reported they had an exacerbation, both prior to reporting of an exacerbation and prior to reporting of stable health. So if I just return to the previous slide, at the beginning of each new time a patient logs onto the myCOPD app, they report whether their symptoms are normal for me, whether they have a mild deterioration, a moderate deterioration, or a severe deterioration. And the moderate and severe deterioration actually align with the clinical the clinical definition of what exacerbation is, and that's when a patient has taken their antibiotics and steroids because they believe they are exacerbating. So for an exacerbation label on day 0, a patient has reported a symptom score of 3 or 4. They believe they've had an exacerbation, and 14 days before this, they haven't reported that they've taken antibiotics or steroids. And we did the same for stable, so 14 days of not taking their oral antibiotics, corticosteroids, and day 0, they reported that their health was normal for me or they had a mild deterioration. And that created good separation. That made sure that we weren't predicting an exacerbation during an ongoing exacerbation, or we weren't predicting that a patient was going to be stable when it's actually just a period of them feeling a bit better during an ongoing exacerbation. And the first thing we wanted to do after creating this label was identify some of the data within the apps that the patients use, whether that is predictive of exacerbations. So this is an extremely low burden approach to predicting exacerbations. In fact, there's no physiological monitoring or active patient input. It's just how the patients are using the app for their own self-management. And at regular intervals, patients are prompted to input data from the COPD assessment test score, which is an 8-item questionnaire about how COPD is affecting their current daily life. So whether it's making their COPD is making sleep more difficult, they're coughing more, they're finding it difficult to do their everyday activities because of their COPD. And this visualization basically shows that the change that from their most recent entry to a baseline CAT score. So when they say the symptoms are normal for me, what is the difference between those two variables? And this is for all the patient cohort that we had available at the time. And so 14 days prior, what is the change for all these patients if they have data before an exacerbation, and 14 days before and after for when they have stable health. And as we can see here, that the change in CAT score begins to rapidly increase as we approach towards that exacerbation window. And actually, we know that the minimum clinically important difference in terms of change in CAT score for an exacerbation is 2. So at about day 4, you see that the change in CAT score from their baseline is 2. So that would be indicative that a patient is having an exacerbation. But even 14 days before an event, there's separation with the confidence intervals not overlapping between stable and exacerbation health. And so this was the first paper that we published on our approach to predicting exacerbations with myCOPD data. And it was I would describe it as an initial modeling approach because we were using really raw features without much feature engineering. Looking at the change in CAT score, their stable CAT score, pack years, age, rescue packs, their dyspnea score, symptom scores, gender, their goal stage, hospitalizations, exacerbation type. So really just bare bones data. And we applied an adaptive boosting algorithm and a variation of the adaptive boosting algorithm called the easy ensemble classifier. And we did this because the data set that we're using is very imbalanced. For this approach, it was 1 in every 44 entries was an exacerbation. And machine learning algorithms are trained on balanced data sets, so you have to take different approaches to try and tackle that imbalance in the data set. And the easy ensemble classifier is a variation of the adaptive boosting model, which works by subsampling sections of the data and then undersampling the class 0, so undersamples the stable health classes, so there is more balance in each subsample of the data set that weak learners of the model are trained on. And this boosting algorithm does this multiple times until it creates a strong learner, which is the model that is applied to see if how accurately you can predict exacerbations. And to begin with, the positive predictive value was very low, and this was within sample training, so not on unseen patient data. So on unseen patient data, actually performed really poorly. But we did identify from this paper that there was predictive capacity within myCOPD data. And we've had a chance more recently to have another go at modeling the data, which I'll go into in a bit. But first, and here we can see that on the right hand side, the performance of the model drastically reduces when applied to unseen patient data. So basically, our current approach to modeling is not the strongest, and we'll need another go at it at another point in time. But prior to this new modeling, we've actually had the chance to work with patients in some co-design activities to get a better idea of their interpretation of AI for use in their self-management. And also some of their feelings about maybe a more intensive approach to monitoring them with wearables and spirometers. So we used purposeful convenience sampling, so basically selecting patients who had high engagement with myCOPD app and also had previously had an exacerbation, because they are the kind of patients who would be using this system to support their self-management. And using a thematic analysis and conducting these co-design workshops, we're able to identify some key themes from these sessions. But I just want to give you a few quotes that really stood out. So even though this wasn't related to any of the questions we were asking them, the patients were immediately discussing how they feel like they're getting subpar care and that their services have been on a decline since COVID. Or since COVID, they've really started noticing a decline in the services that were previously available to them. And I think they brought this up in relation to that this is something they would support. In fact, they really, after expressing their concerns with the NHS, said that they're very much behind us developing some kind of AI support that could help them identify when exacerbations were going to occur. But then when I showed them the accuracy of the models that I've just shown you all, they expressed a lot of dissatisfaction with that current level of accuracy and felt like they wouldn't trust it in their day-to-day lives. And they expressed this idea that for them to trust an AI in their self-management, it would be something that would have to happen over time. So with more correct predictions of stable health and exacerbations, the more they would trust in it. And they also expressed that if it was to be wrong in a prediction, they would probably lose trust in it very quickly and maybe put it down straight away if it was wrong. So that was something that was really important for us to consider going forward and was really useful to have these discussions with patients. And so that leads us on to the next stage of this project, where we received some funding from the AI4CI Hub to model the myCOPD data a bit further and identify if we could improve that prediction, maybe get it closer to a level that patients find more acceptable. And also we were able to use integrated wearables. So sometimes patients connect wristband wearables to the myCOPD app, and they have their step data recorded within the app. And so seeing if the additional step data could enhance our predictive performance. And this really aligns with the AI4CI Hub's goal, which is using that collective intelligence, and that's the collective intelligence of the patient, of a large number of patients, 40,000, 50,000 patients at this point, logging onto the myCOPD app and reporting their symptoms, how they feel, using the different features within the app, logging their step counts, and using that collective intelligence and AI to maybe at some point inform their behavior and inform their decision making around exacerbations. So in this second analysis, previously I had been working with 500 patients because I really isolated it down to a group of really engaged users who had experienced exacerbations. But in this cohort, just lowered the threshold for being involved in the data analysis and just kept it to if a person had experienced or reported an exacerbation one time within the myCOPD app, then they were going to be included in this more recent analysis. And the age and gender of the groups are what you'd expect in this cohort of myCOPD patient users. And also the distribution of severity matches, again, what you would see in the COPD population. The gold grouping C is much lower than normal, but that's because there's been a recent change in the gold grouping. So gold grouping is related to disease severity in terms of what medications patients are taking and their exacerbation frequency. And now it's just A, B, and D. And that is a reason why you see a much larger proportion of patients belonging in D and some in B. And the MMRC score relates to dyspnea, so reporting of breathlessness, and just a normal distribution, maybe slightly skewed towards the left, with a lot of patients being, having some level of breathlessness compared to zero having no levels of breathlessness. Their PAC year is again similar to what you would see in a typical patient population, as well as their smoking status. So most patients belonging in current smoker or ex-smoker. Again, with hospitalizations and their rescue pack use, there's a real hospitalizations. Very few people were in hospital last year, what you'd expect from this population. And then, yeah, most people having a handful of uses of the rescue pack medication, and a handful reporting to having used them quite a lot. So yeah, representative of typical patient population. We knew this wasn't a different cohort than what you'd imagine people who haven't had reported an exacerbation to be within the app. So our approach to modeling this data was slightly different. So in the previous approach, we'd used, 10 kind of static features, and then the change in CAT score and symptom score as more dynamic variables. And we were looking at a 1 to 7 day prediction window, so whether they're going to exacerbate in 1 to 7 days. And from previous investigation, we identified that moving this window to are they going to exacerbate in 1 to 3 days time massively increased the performance of the model. We also shifted away from using the adaptive boosting algorithm to gradient boosting, because a lot of the evidence suggests that this might be better at handling this kind of problem. And also it's very good at handling missing data. So previously I'd kept the data set, so only actual data the patients had entered could be used in the algorithm. But now there was a lot of missing data involved, and so it actually enabled a kind of a much larger data set than I previously modeled on, allowing for missing data. And also applied a lot of feature engineering to the data, so lag rolling and trend-based measures, so the standard deviation of the CAT score over 7 days, the mean CAT score over 7 days. When did the patient last report that they had a symptom score of 3 or 4? So did they have an exacerbation within the last 90 days or the last 30 days as reported in the app? And we're using the COPD assessment test score, their symptom scores, their steps from the Respiratory wearables, medication data, pulmonary rehab data, and also their static clinical data like smoking history, disease severity, MMR dyspnea score, those kind of variables. And to evaluate the efficacy of our modeling approach, we used a group nested cross-validation methodology, which keeps unseen patients on multiple outer folds of the training. So we're able to see in multiple iterations how generalizable the model will be, because if you just trained it in one singular instance, the model might perform very well on this test data and maybe not so well on another group of unseen patient data. So this methodology enables us to see how well our model might actually generalize if deployed in a real world situation. And so already the performance was much better than I previously had got. The receiver operating characteristics showed much greater separation, so it was performing much better than random. And also the baseline prevalence of exacerbations was about 5%, and the precision recall curve went up to nearly 30%. So in terms of going towards a positive predictive value that I think patients would find acceptable, that is a significant improvement. That's nearly 8 times improvement on what I had before. So I'm pretty happy with how things have turned out. But and also when you look across the folds as well, there is not much variation between each fold. So the model is stable. It probably does perform as it says it would in if it was to be deployed in kind of a real world situation, with the precision reaching about 30%, so the positive predictive value being about 30%, and the sensitivity being being above 40%, so correctly capturing 40% of exacerbations, which again I think is not too bad for just patient entered self-management app data. And then so recently been reviewing some of the most important features that the model uses. So the previous exacerbations being number 1 and number 3, and that's actually quite well documented in the literature. If you've recently had an exacerbation, you're more likely to have an exacerbation in the future. The number of CAT scores being the second most important was an interesting one, and I haven't really determined why that's such a powerful predictor. Could it mean that there's just more data available from them, which means that it's easier to make a prediction of? Or is it because the patients who are more sick are often engaging with the app more, and so they're more likely to exacerbate? I'm not entirely sure. The symptom score, the 28-day mean, and standard deviation also being important, days since their last exacerbation being important. This kind of information from the feature importance, I think, gives a good indication that patient symptoms and recent exacerbations are driving that increase in model prediction. But in the top 20, didn't see any of the physical activity of step data being an important measure for the model. And that was something that we thought would be quite a powerful predictor. So we went on to try and investigate, or I went on to try and investigate if the step data had any enhancement. But this is I added this clinical interpretation in case anyone from a clinical background was listening, just to give them an idea of what those metrics of machine learning meant, so the precision kind of relating to positive predictive value and recall relating to sensitivity. So having a look at the daily step counts, the first thing I saw was this group of people who is using risk-one wearables. They're probably doing more steps than you'd imagine a person with lung disease doing, kind of going towards 5,000 steps a day, which is more than I get on some days. So these are probably quite physically active people who are using wearables alongside the myCOPD app. And then I included this visualization because I thought it was quite nice. I was like, what the hell's going on? So during Christmas, I think people suddenly get their Fitbit or Garmin and then they take it out for a walk. I thought that was quite funny. But yeah, as you see in the summer, people are going out more, it's nicer, and then towards winter, you start getting people are staying inside more, wanting to go outside more, and then Christmas Day, boom, everyone's going for a walk. So yeah, quite fun. So the first thing I did to see if step count was affecting the data was in that sample of 5,000 patients. If I took away anyone who had the step data, would that affect the model performance? And there was no real difference in that. But then reading into it, there was 900 patients of that 5,000. And of that 900 patients, I think it was something like 469 who had an exacerbation. So after that, I decided to model only those 469 patients who had a wearable and exacerbated. And then I had all the data that I had for all the FEAST studies before and include with and without steps. And again, couldn't really see any difference in the model performance. It's pretty much identical or very small variation between the folds. So from that, you have to conclude in this instance, step data isn't really affecting model performance. And these were my theories of why that might be happening. Maybe they're a healthier, more active group, not enough variability in activity when patients are exacerbating. Maybe the symptom predictions are so strong that the steps can't add anything above them. I did a little bit of investigating as a good scientist should do. And this visualization represents when a patient is reporting their symptoms being normal, what is their step count? And then this is their most recent score compared the difference from that kind of step count. So when a patient is stable and exacerbating, and the confidence intervals are completely overlapping between the two, so there isn't really a significant difference in step counts from a baseline between the most recent entry of step counts. And so that is probably why we're not seeing an incremental improvement in day-to-day isn't kind of much of a difference. So going on from this, what are our plans? We published a systematic review looking at other research groups looking at remote patient monitoring with machine learning. And from that data, we've seen that physiological variables are really powerful predictors of exacerbation, oxygen saturation like SpO2, respiration rate, heart rate, these kind of more dynamic objective measures. Other things like pollution monitors in the environment as well, we saw could also be quite powerful predictors. And really need to move away from remote patient monitoring alone, as that's far too high resource burden, and focus on machine learning with these variables and also using co-design with patients to make sure these technologies align with what they want properly. And we met with patients again and asked, would you be willing to use sensor technology if you knew it could improve flare-up or exacerbation prediction? And again, everyone was very supportive of using any kind of digital wearable that might predict a flare-up. We provided some patients with wrist-worn wearables, pulse oximeters, digital spirometers. And it's really funny because most patients were like, I can't wait to use the digital spirometer. It's going to be so interesting to see what my lung function and readings are. And at the end of it, they said, never show me one of these technologies ever again. Because as you can imagine, if you have a lung disease and you're having to blow into something every single day, and you might have an exacerbation soon, that was obviously quite a challenge to do. One chap said that it would take him 7 or 8 goes for it to have a reading. So after that, we decided that we probably wouldn't include any kind of spirometry measure in the future. And that leads on to where we're going next. So we're trying to build a platform where we include wrist-worn wearables where we can measure those physiological variables, combine it with patient-entered symptom scores. So what we've learned from our modelling is that symptoms and patient self-report can be powerful predictors of modelling. We've seen in that precision of 30%, that is already quite a high precision just from symptoms, let alone physiological variables. And also we want to see if in-home environmental monitoring, looking at temperature, humidity, pollution, that will also provide some indicators of exacerbations. And that is the trajectory that we want to take this research in now. So I want to take this time to thank all the people who've supported me on my research journey and all the organisations who've also invested grant money in this research as well. So thank you very much, everyone.
Is there any questions in the room? I'll go first.
Yeah.
So you said you're using XGBoost to perform the prediction. Have you thought about like other stuff like neural networks?
Not at this point. I just don't think the data set is big enough for justifying neural networks, to be honest.
But it's what, 20,000 from the app, or?
So there's 22,000 active users and there's 5,000 patients, but I would say that app use is sparse, basically. So in that group of 5,000 users, there's probably there's a paper published on different levels of engagement within the myCOPD app, and having more than 20 entries within 100 days is the highest engagement group. So the actual amount of data is not, I don't think applying a neural network to the volume of data would provide any improvements than you see over the XGBoost algorithm. At this point, maybe with incorporation of much more data from the physiological wearables, more daily data, or more data by the second, then we could think about incorporating neural networks. But I think at this stage, probably. There we go. Yeah. Sorry.
Thank you, very interesting project. My question is more about what's the final goal of this project and digital solution. So is the expectation that once the patient basically knows from the app that they are about to their symptoms are about to exacerbate, they self-manage and report promptly, and therefore maybe they take some medication to prevent, the exacerbation? Or is that this app would be sort of integrated in the clinical pathway somehow, and therefore the medical team that basically is caring for this patient will be notified that this patient is close to sort of a crisis?
Yeah. That's a very good question. I think it's quite hard to determine at this stage. I think I want to be very careful with where the FORESEE platform goes with advising patients on whether they should or should not take medication, because then you go to different levels of regulatory pathway, and then those regulations can be extremely costly. At this moment in time, we're viewing it as potentially an advisory tool where it's and this needs to be worked out with patients as well. So I don't want to say anything too definitive because I want to go through rounds of the person-based approach and co-design, but we're thinking potentially along the lines of a traffic light warning system where green means everything's okay, amber is there's a slight, the AI has detected increased probability of exacerbating, so maybe be more vigilant, and then red, that would indicate that the probability of the AI thinks a very high likelihood of an exacerbation, and then maybe there is a more definitive, we advise you for much more enhanced monitoring, or maybe even getting in contact with your GP. But I think this is really needs, and it's good to think of these things now because of regulation pathways can be really costly and expensive. I think it's more going to be a self-management tool for patients.
Yeah, but they currently we're not getting any predictions shared with them. So how do those people come to be using the app? What's their reason for using it? Is it just tracking?
Yeah, so there's lots of tools that myCOPD provides patients with. So a lot of the time they're using it for my pulmonary rehabilitation, which is a kind of exercise course. It's a validated clinical tool for improving patients with COPD with their lung function. So and you can get this kind of guided tutorial in app. So a lot of patients use it for that. There's other things as well. So they use it for medication tracking. They use it for educational techniques. They can even look at weather data like pollen and pollution that might affect exacerbations. But every new day they log in, they do this symptom report saying they're normal, mild, moderate, or severe. and they have to do that before they go into the app. And that's how I've managed to draw down whether or not patients are exacerbating. All this modelling has been happening completely externally to the app, so there's been no information fed back to patients, basically. Yeah, they're referred by a healthcare professional. Yeah, exactly. There's not a huge, I mean, most patients are somewhere between 50 to 80 years old. That's where they lie. Yeah. No worries.
We have a question online over there. Who ask, are there any privacy concerns about storing all of that data centrally? And have you considered any federated learning to address?
At this moment in time, there's definitely no concerns because it's all completely anonymized. I mean, there's no tangible link to any patient anyway. There's no linkage of postcodes or names or anything like that. I get raw numbers from extracted from my own health, so I don't think it's even pseudo-anonymized. I think that would be under anonymization. Maybe with the FORESEE platform that we're planning to develop, then we need to start considering about how we deal with these kind of privacy issues. And I'm definitely thinking about that now at this point, but yeah.
Okay, I'll ask. Do you consider anything? Do you consider environmental factors like geolocated air pollution slash pollen?
So during my PhD, I actually discussed this, but I think what we're going to do now is, when I met with my COPD patient users, they basically said they purposefully never leave the home because they're worried if they leave the home, they're going to be exposed to cold viruses, pollution, pollen, and that's going to make them exacerbate. So they tend to not really leave the house, and if people do see them, then they'll come and visit them. So for FORESEE, we have this monitor called Air Gradient 1 that measures pollution within the home, temperature, humidity, particulates, all those kind of things. So I think if an individual is going to exacerbate due to environmental factors, it will probably be because of some kind of environmental change within the home, maybe gas stoves or not opening the windows or pollen getting into the home maybe. So probably not.
And ask a bit about the other features you're using as well, like what features are you using with your model and stuff?
Well, we're currently building the FORESEE platform right now. So it's only, we first built the back end. So I don't know yet.
And
yeah.
Yeah, so just so you said that the physiological variables were the strongest predictors.
When reviewing the literature, not in the evidence that I've, yeah.
So
the strongest predictors for our projects are the CAT score and the symptom scores. So even though self-reported data, exactly. Yeah.
So you didn't see any sort of correlation with the step count?
No. But I think that is because of the population who is using the wearable itself. They are probably a bit healthier and more active than this wider population of app users, and so it's probably harder to predict exacerbations. With the models performed less well in this population of users who have these wearables, and also I don't think step data in that population will be useful. I think maybe if it's provided to a person, so these people who are engaging with the myCOPD app, they've bought themselves a Bristol wearable, they've connected it to the app, so they're already much different from everyone else using the app. In the case of FORESEE, we'll be providing them with the technology, and they won't be walking around so much. So maybe at that point, you'll see that physical activity data might be more of a predictor in patients who are less mobile or who are more sedentary, basically.
You said that there was data balance in the how big was the balance in terms of data stuff, and also what things did you use? Because I believe you said from like unsampling the data stuff you did as well.
Yeah, so in my first pass, in the first paper that I showed you, the ratio for that was 1 to 44. So I read this paper about the easy ensemble classifier, and that basically said how we tackle unbalanced solutions is random bundle sample in the training data set. And I thought that sounds like a good idea, and I applied it. And then as I progressed through my PhD, and I'm reading about the XG boost and how it has an inbuilt system for scaling weight to more difficult to classify instances. And I think that's why one of the bigger reasons why the XG boost work much better than the easy ensemble classifier, because rather than missing, you're just getting rid of large swathes of data, even though you are kind of resampling them in the instances of the learning. I think the methodology of the XGB, I think most up it was 30 times, the weighting was times 32 towards the exacerbation. I think that made a big difference for prediction in the second phase of modeling that I've done. Thank you.
No more questions online or anything?
No, I don't know.
You did say that you still hold out some hope for some measurements from the wearables. Presumably, if it's not step count, what other ones you've got in mind?
So I think from the literature, there's a paper by John Hurst, and it basically showed that cardiorespiratory variables overnight are very powerful predictors of respiration. So heart rate, oxygen saturation, and respiration rate while sleeping, those changes are really powerful predictors. And so if I'm already getting 30% positive predictive value from patient-reported symptom score, how far can we go with overnight cardiorespiratory variables? I think much further. And having these conversations, so far there was a technology called COPD Predict, and they have the highest positive predictive value so far that I've seen, which was 50%. And they did a phase 3 randomized control trial, and I don't think the AI performed better than the patient's own intuition. So you're looking like you need to get a positive predictive value much beyond 50% to be better than the patient's own intuition. When I was talking with patients, they kind of said they want it to be 90%, which I think is maybe impossible. But it would be hard to say without. I'll be very interested to see what these variables add to the predictive performance.
How do you measure, so you can measure cardiac with the wearable, and measure respiratory with it?
So I think the PPG sensor does both heart rate and respiration rate. It can do both. So because we use, for the FORESEE platform, we're going to use the Garmin device, and that's what it says. It uses the PPG for both heart rate and respiration rate, and then it uses another sensor for oxygen saturation, I think.
Might be a slightly intractable problem.
Yeah.
It was really interesting you talking about patient's intuition, and they know internally something is probably about to kick off. Is there any attempts or any value in trying to unpick that with participants and articulate that into some kind of feature eventually?
No, I definitely agree with that, and I think that's why doing co-design activities alongside these machine learning studies is so important, to understand how patients will respond to them. Because if in the study where they saw patients' own intuition was as good as the AI, why do we still see that patients are delaying taking their medications? Why are they not treating exacerbations when they think they are sick? So working alongside to unpick medication hesitancy, response hesitancy, why having something looking over your shoulder saying it's looking like you are going to exacerbate, that might just give you that confidence to take the medication in a more timely way than you were before. But no, that's exactly what we hope to unpick with this with co-design activities with the FORESEE study as well. Thank you.
So I think you mentioned that the forecasting will be routine 1 to 3 days. Was that chosen based on a co-design study and also?
Yeah, but so in my first paper, it was 1 to 7 days, and then during my PhD, I basically had to mess around and was looking at time windows, which are most predictive, or as you get close to the exacerbation, does the prediction get better? And then 1 to 3 days, it was the strongest prediction window. So for this latest study, I thought 1 to 3 days would be best, because then I get the best looking models.
Okay, and does the accuracy change a lot, predicting 1 day compared to predicting 3 days?
I haven't tried that with this current data set and this model, but maybe I will do next. But the key purpose of this study was to see if the physical activity data was going to add any value to the models, which it did not. Yeah.
The predictive model is mainly for basically the timing of treating this exacerbation.
Yeah.
So that you avoid being hospitalized. Okay.
Good.
Doesn't see any questions online.
No.
I think we asked actually quite a lot of questions already. So I think,
Like it was my Viva.
then I think we can leave it there to just thank everyone once again.
Thank you.